If you have that classic bullseye rash, then you can make a presumptive diagnosis of Lyme disease. But if that rash isn't noticed or if it's not present, then the patient may go undiagnosed. That's where the real gap exists. And that's where researchers, scientists in my laboratory and other laboratories are looking for tests that will allow us that diagnosis in that early stage.
If you spend time outdoors in the warmer weather, especially where there are lots of trees or grassy areas, watch out for tiny deer ticks. A bite could put you at risk for developing Lyme disease. Lyme disease and other illnesses like Zika, West Nile virus, and dengue fever are called vector-borne diseases. They're spread by bugs like ticks, mosquitoes, and fleas. They're becoming more common. Diagnosing them can be a challenge. That's ahead on this episode of Tomorrow's Cure, a podcast from Mayo Clinic that brings the future of medicine to the present. I'm Kathy Wurzer. Thanks so much for joining us. Well, friends, this promises to be a fascinating conversation. The world's foremost expert on Lyme disease is with us, Dr. Alan Steer. He's a medical researcher and rheumatologist. He's a professor of medicine at Harvard Medical School and is the director of translational research in rheumatology at Massachusetts General Hospital. 50 years ago, it was Dr. Steer who identified a cluster of children in Lyme, Connecticut, who were suffering from arthritis. That led to the identification and description of Lyme disease. Over the years, his work has also helped develop treatments and vaccines for the disease. Joining him, Dr. Bobby Pritt. She's the director of the Clinical Parasitology Laboratory at Mayo Clinic, and in 2016 identified another species of the bacteria that causes Lyme disease. Her work has helped create faster and more accurate tests for a number of diseases that plague us humans. So pleased that both of you are with us. Thank you so much.
Thanks, Kathy. It's such a pleasure to be here.
And Dr. Steer, thanks for being with us.
Thank you very much. Happy to be here.
My introduction mentioned just a handful of these vector-borne diseases. Some are very serious, life-threatening consequences, as a matter of fact. What do we know about why the bacteria, the parasites, the viruses passed on to humans by these vectors are so threatening?
Well, I'm sure there are multiple factors. One is that these are often unusual organisms that humans have not seen before and consequently don't have long developed immunity against them. But actually, I think it's the story of infectious diseases as well. Many organisms have a great variation in the population in severity. In fact, whenever I make a statement like that, I also add, and that's why we're still here on the planet. We don't all react in the same way. And that's very important in survival. But certainly, a number of the more recently identified organisms that can be transmitted by the deer tick all have at the far end of the spectrum quite serious consequences.
Dr. Pritt, would you like to join us and maybe talk about what you think is going on?
Well, I agree completely with Dr. Steer. And I also think it's important to note that a lot of these organisms have been evolving for many, many years, hundreds of years, thousands of years. And we now have a wide variety of these organisms that can be transmitted by ticks and mosquitoes. And sometimes humans come into contact with them and we don't have that pre-existing protection against them. And so in us, we actually get quite serious disease. It could even be fatal.
You were both presented with patients who were very sick, young patients, as a matter of fact. Other physicians couldn't figure out what was going on. What led to ticks, Dr. Steer, as the source of the bacteria that causes Lyme?
I had been at Centers for Disease Control. It was the period of the Vietnam War, and I was doing outbreak work in trying to understand what was happening with a number of infections in hospitals. But I left that to go to Yale in a rheumatology fellowship. And 4 months after getting there, heard from a fellow person I had worked with at CDC that he'd been contacted by 2 mothers in Lyme, Connecticut. And they told of a number of children with arthritis, and So many, as a matter of fact, that they just thought there must be an explanation for it. How we got to ticks as the reason for what had generally been diagnosed as juvenile rheumatoid arthritis in children uh, was, well, both the clinical and the epidemiologic fingerprint. In other words, this is how one evaluates a cluster. And within that cluster, first of all, the infection had often begun in the summer or fall. There was also a history of an unusual skin lesion before the onset of arthritis that some of the parents thought was likely an insect bite, but like one they'd never seen before. And then there were multiple people affected, sometimes in the same family, and it included parents in some instances. But when a family had been affected, usually they'd had the onset in different years. What I've been saying adds up to making one think about what's called an arthropod or an insect-transmitted illness. With that information, some people came forward and said they thought a tick had been attached and bit them at the site that this unusual skin lesion developed. So for all of those reasons, we came to really focus on ticks, actually within months of starting to do the epidemiologic investigation. But it took another 8 years to get to the organism that was actually causing the disease.
And Dr. Pritt, you found, as I understand, 2 never before identified bacterial organisms carried by ticks that were making people in Minnesota and Wisconsin sick. What was your aha moment?
Well, for us, first of all, I want to give credit to the people who are boots on the ground, our laboratory technologists that are doing testing every day. They noticed that something was atypical in a positive result for a test we were running first for Ehrlichia species, a tick-borne bacterium, and then later for a Borrelia test that we were running for Lyme disease. Both cases, a technologist noted it and said, this doesn't quite look right to me. And I took that and started reaching out to colleagues. We did additional experiments. It was a great collaboration with the CDC and our state and public health laboratories. And I think what was really important, especially in the second case, when we discovered the second cause of Lyme disease in the United States, is that we had a patient who was a young child who was very, very sick and had this unusual presentation with small rashes all over his body. And so it just didn't fit the classical presentation of Lyme disease, but we had a result that looked like it might be Lyme disease. So really, it's a team effort coming together, and also the persistence of saying, no, this doesn't quite look right. Let's pursue this and investigate a bit further.
And so what did you say when you made the discovery?
We were really all surprised that we were detecting something that appeared to have never been detected before. This is an organism we eventually went on to call Borrelia mayonii after the Mayo brothers that found it Mayo Clinic with their father. And it really, being able to grow it in culture, identify antibodies to it in the patient's blood. Those are all the puzzle pieces. Like Dr. Steer was talking about, an epidemiological investigation can be very complex. It can be puzzling. It can also be very rewarding when you put all the pieces together. But it's an important one nonetheless.
I like hearing the background as to how things are discovered. So thank you so much for telling me that. When presented with a patient's symptoms, is it clear to physicians that they're dealing with a vector-borne disease? And I ask that because, Dr. Steer, there's the bullseye rash for Lyme disease that everyone knows about, but I understand there are stages to Lyme disease. It might be helpful to talk about those stages and if doctors really understand what they're seeing when a patient comes in.
Lyme disease is transmitted by an immature stage of the tick primarily. It's called a nymphal tick. And it, in the Northeast, is most active from about mid-May through mid-July. Well, there may not be specific symptoms when the patient comes in that would tell them this is a vector-borne disease. There may be symptoms that we commonly see with infection, such as fever, but then that may also be absent. And as an example, with arthritis in children in Lyme, Connecticut, for the most part, they had no history of preceding illness. So they were presenting with what a physician would usually think is an inflammatory autoimmune disease rather than an infectious vector-borne disease. So medicine is complicated. That variation in the way people present is certainly true in Lyme disease. The first stage is usually a slowly expanding skin lesion, redness, that develops at the site of the tick bite and expands slowly. That's the most, typical presentation of Lyme disease. But it's not always there, and even if it is and it's not recognized, other symptoms will often develop. So the organism may spread in the blood to other sites, and it includes the nervous system. The meninges, the lining of the brain, may become infected. Facial nerves may be affected and paralysis. Peripheral nerves may be affected so that one has radiating pains in, it can be the arms, the legs, within the chest, which can be very painful. These signs, again, would not necessarily lead one to think infection. The heart may also become affected. It seems particularly athletic men are more prone to this particular complication, though it is not a common complication, in which heart block develops. So the electrical system in the heart is not able to function appropriately. So that's we call an early disseminated phase of the disease, but there are later manifestations that can develop usually after a latent period. So it's months later. It can even be as long as, a year or two later. Arthritis develops, and it most commonly affects a knee or both knees, but it can affect other joints. There can be late neurologic manifestations as well.
Oh my goodness, Dr. Pritt, what a complex condition.
It really is complex, Kathy. And my job as a pathologist and microbiologist specializing in laboratory diagnostics is to have tests that can detect the disease, make an accurate diagnosis at all these different stages, and also help my patient-facing colleagues like Dr. Stier and other physicians that see patients directly know which tests to order. Because obviously, you get these diverse symptoms. It depends on the stage of the presentation of the patient. Early on, if you see that nice classic bullseye rash in the right setting, testing isn't even indicated. At this point, you can usually, with some confidence, make a diagnosis of Lyme disease, although there's some caveats to that I'm sure we can discuss. But then later on, when it starts involving the central nervous system or the joints, there are different types of tests that might be indicated. And we didn't talk about this, but this is just Lyme disease. There's the whole host of other vector-borne diseases that are presenting usually during the spring and summer, but also into the fall whenever the ticks are active. They could be biting. And then you can have these other diseases that cause fever, anemia. So often there's a broad differential diagnosis, and perhaps performing just a single test might not be the approach. In my laboratory, I've worked with my colleagues to come up with panels of tests in an algorithmic approach. So based on the patient's symptoms and where they've been exposed, we can perform different tests to make sure we're covering the most common organisms that might be there. And sometimes that even includes things that are not transmitted by ticks. The tests that we have their strengths and limitations. Right now, talking specifically about Lyme disease, the gold standard for many, many years now, and decades even, is an antibody test. You're detecting antibodies to the organism. Well, that's great if it's later on in the disease and your body has mounted a strong antibody response. But what happens if it's in that first 1 to 2 weeks and there's not a strong detectable antibody response? You'll get a false negative. And we know that's a limitation of the antibody tests. If you have that classic bullseye rash, then you can make a presumptive diagnosis of Lyme disease. But if that rash isn't noticed or if it's not present, then the patient may go undiagnosed. That's where the real gap exists. And that's where researchers, scientists in my laboratory and other laboratories are looking for tests that will allow us that diagnosis in that early stage. But later on, the antibody tests that we have are actually quite good at detecting those late stage manifestations.
There's another problem, and that is the amount of antibody increases as the infection goes on, if the infection goes on. And one treats with antibiotic therapy in appropriate ways, usually responds well. And then the amount of antibody declines, but the test remains positive. If the patient had Lyme arthritis, a late manifestation, the antibody tests may stay positive for years. Actually, that's not a bad thing. That is immunity. Now, if you're in an endemic area, you may be bitten by ticks multiple times. You may be exposed to the Lyme disease agent or other agents multiple times. You're less likely to get at least severely ill with it on a subsequent time because of having had an antibody response memory of the previous infection that persists. Well, if we do testing for antibodies, that test just remains positive. It doesn't mean you still have the infection. So that's the limitation of it. What we would really like is to have something that is truly associated with the infection itself. And of course, the best thing is to be able to identify the organism or at least some component of the organism by testing for this particular protein or for the organism itself by culturing it, which is, of course, the best way, but very difficult to do in Lyme disease once late in the infection. Bobby, do you want to pick up on that and talk about, well, newer ways of trying to deal with these limitations of our current tests?
Yeah, I'd be happy to, Alan. We're looking at ways, a lot of people are looking at ways to diagnose in that early window. That is the real difficult spot before antibodies are formed. You could try detecting the molecular information of the bacterium, the DNA, but that's not very sensitive because there's just not a lot of it in the blood. You could also look for antigens. You could look at the host immune response. It looks like probably a combination of those things is going to be helpful. And then, of course, this is just Lyme disease, but there are all the other tick-borne pathogens that someone may have. And so I had talked about panel or algorithmic-based approaches. The new exciting thing that a lot of people are talking about and we're working on in my lab is something called metagenomics. Meta meaning many genomes. You can detect the genomes of many different bacteria or even viruses or parasites in a single specimen. And I think that's the way the field's really going to go, because then you don't have to go in thinking you're testing for just a single organism. You could test for a syndrome. A patient has a febrile illness during the summertime, could be a tick-borne or mosquito-borne disease, or it could be something like leptospirosis, which isn't tick-borne at all. And so we have a metagenomics test now that we do on blood. And lo and behold, we have detected diseases that are not transmitted by ticks, but the physician thought the patient had a tick-borne disease. But again, they still need to come a little bit further. They don't quite have that sensitivity for detecting Lyme disease in the early stages. I would say the molecular tests are better for the non-Lyme tick-borne diseases. So we have a bit of work to do, but a lot of exciting things going on in the field.
As a clinician then, Dr. Stier, if this is groundbreaking and new, what's a physician to do at this point? Where's the path forward for them?
The first thought that comes to my mind is that the practice of medicine is humbling, or it should be, that we should be humble in the face of what we're not sure of and what we don't know. And we bump up against those limitations, both clinically, when the disease is complicated or the patient's not responding in the way we expect, and we bump up against those limitations in laboratory testing. But having said that, I can emphasize the other side of things, which is in most patients, we can identify at least certain of these organisms. And so I'll take the Lyme disease agent as an example. We can identify these organisms from, that a person has been exposed to them at any rate, from antibody testing. And we do have antibiotics that generally work quite well in the treatment of these diseases. Doxycycline would be an example of an oral antibiotic that usually works well for most patients. So even though we can't, or we have difficulty still and progress needs to be made still, there have also been real strides in identifying these organisms and having the antibiotics to treat them effectively.
We've been talking about the severity of these vector-borne diseases, Lyme disease and others. And I can't tell you how many news stories I've done in just the past 5 years where we talk about the spread of these various diseases. And as I mentioned in my introduction, they're becoming much more common. What's behind that? Is it climate change, perhaps? Is it changing land use patterns? What's the thinking at this point?
So it's probably multifactorial. Climate change probably does play a role. As temperatures get warmer, ticks can move into new areas and actually survive. That even includes the harsh Minnesota winters. But also the hosts can survive, the deer, the mice, the animals that these ticks feed on. But land use definitely plays a role. And when we have habitat fragmentation, little areas of forest and woodlands where they are separated and there's not broad distribution of animals across them, that seems to be a very good setup for the animals that can harbor Lyme disease and the ticks that can transmit Lyme disease. Then, of course, there's human activity, humans going into those areas, humans encroaching upon wild habitats and getting exposed to new tick and vector-borne diseases. And then if you're looking at a world picture with global vector-borne diseases, you have to factor in global travel. It's easier than ever to circumnavigate the globe and spread things that might have been in a very remote corner of the world across the globe in a very fast manner.
When is prime tick season? Now, I know, Dr. Steer, you're on the East Coast, but generally speaking, what does it look like nowadays, especially with climate change?
In New England, the peak time is really early summer, but periods of risk have spread out. And in California, for example, where the disease is more sporadic and episodic, it seems to be a risk, nearly year-round. So it makes a difference where you are. The thing that in nature controls ticks the best is the average winter temperature. And the colder, the less likely that ticks will be able to survive. So up there in Minnesota, Bobby, you have the best weather for tick prevention.
Yes, but with our milder winters.
We're having milder winters.
Oh,
Boston
yeah.
used to have terrible winters. Very difficult.
It's changed.
And
Yeah.
we happen to have had a pretty cold winter this year, but it's less so, much less so than it was.
So it's essentially as soon as the snow melts, the ticks can come out. So as Alan mentioned, of course, it's the early summer that's the peak, but you can get bitten by a tick in March or even February, even in a place like Minnesota, if you're having a mild winter. And then, of course, there's the second peak in the fall, and that's when the hunters and hikers and people outdoors are out and they're getting exposed. So unless there's a foot of snow on the ground, and the ground's not frozen, I think you have to think about potential ticks and tick bite diseases.
One does need to think about tick and tick-borne disease as a risk in certain areas of the country and under certain conditions. But, more and more, It's happening in suburbia as well. So for some people, they don't have to go out for a walk in the woods in order to be exposed. Um, I think being aware of this, having tick checks at the end of the day, particularly with children, can help. It's also been pointed out that you can choose to do areas with your yard in the way of spraying. In other words, there are certain chemicals that are thought to be safe, but will still kill ticks. And you could make the decision to do that with your yard. Um, I've had patients, where they'd had multiple tick-borne diseases, and doing that, really taking care of their yard in that way seemed to be a real help in preventing the disease. But we're really left with personal protection measures, which kind of amount to awareness and certain things you can do with tick checks, as well as things that you can choose to do with your yard if that really is an area of danger for you.
I'll just add on to that too, that thinking about adding a barrier between the wooded areas and your lawn, it could be a hardscape, gravel, for example, seems to have some benefit. Keeping the ticks crawling into your yard and then keeping your grass mown short can be helpful. And then I'll just mention one last thing is don't forget your pets. If your dog is going outside, the dog can bring the ticks inside. Of course, the dogs can get Lyme disease and other diseases as well. So you want to check your dogs for ticks and make sure that your dogs are up to date on their vaccine. But also think about the fact that those ticks can get into your house by your pet, even if you do all the right things.
I wonder, because these diseases are becoming more common and spreading, as we've been discussing, what are the prospects, say, of prevention, the prospects for vaccination? What does that look like on the horizon, Dr. Spear?
Oh, what a question. I think we've had a safe and effective vaccine for Lyme disease for over 20 years, and we've actually known that. I mean, it was shown in the late 1990s, but there's been marked opposition. Lyme vaccine was on the market for only 4 years. I think it was a safe and effective vaccine. There's always the question, at the far end of the spectrum, can it cause certain side effects that we don't want? We were not really able to show that with the Lyme disease vaccine, but it's still a consideration. The vaccine was directed against outer surface protein A of the spirochete, well, to make an immune response to it, an antibody response to that particular protein, which had been found to be protective in mice, but it certainly, we showed in the 1990s that it was effective in human beings as well. It did require booster injections, and how long that would need to go on was not clear. But from anti-vaccine movements, the manufacturer decided it just was not worth the risk. And so we have not had the vaccine available to us. It's available to dogs, by the way, but not to us. So Pfizer is, I think, completing phase 3 trials now. Will the vaccine be brought on the market? Will it be approved? How is that process going to work now is just not altogether clear. I would point out something about vector-borne diseases, though, in terms of vaccination. Let's start with the idea first, though, of COVID, a respiratory infection. Their herd immunity is very important. There's person-to-person transmission, there's airborne transmission. If your neighbor has it, you're more likely to get it. If your schoolmate is infected, you may become affected. Large gatherings, you may become affected. With a vector-borne disease, it is the tick that transmits the disease. So if your neighbor decides, I don't want to be vaccinated, well, fine, you don't have to be. And if you decide you want to be, you can do that. But in other words, the idea of herd immunity is not important with a vector-borne disease.
The preventative measures are still going to play a large role, especially because we have a vaccine coming out for Lyme disease, but we don't have vaccines for anaplasmosis, babesiosis, Powassan virus infection. We didn't even get into the whole list of other tick and mosquito transmitted diseases. So you still are not going to want tick bites. You're going to want to prevent those. So staying away from the areas where the ticks are biting or the mosquitoes or the other vectors, staying out of the long grasses, staying on the path, for example. If you're going into the tall grasses, tucking your pants into your socks, it's just going to give the ticks less skin to latch onto. And then doing those frequent tick checks are important. You want to catch the ticks before they embed, or if they do embed, you want to remove them from your skin as soon as possible. That's going to decrease the likelihood of that transmission from the vector, the tick, into us. So that's all very important.
Dr. Stier, you've been doing this, well, as I say, it was 50 years ago when you discovered the Lyme disease outbreak in Connecticut. What keeps you both focused on finding new breakthroughs?
I do think there's been progress. In fact, I thought about this earlier when you were describing, gee, what was your reaction, Bobby, when you saw the infectious agent or evidence of it at first? And thinking about how what happens in science and research is on most days, you try something and it doesn't work. That's the average day. But on the other hand, the great day also frequently comes when you see an insight and greater understanding, and it really does make a difference. It makes a difference for patients. And over the course of 50 years working on Lyme disease, I remain engaged in the fact that I think progress is being made, and I just like being a part of that community.
And Dr. Pritt?
I agree completely. Being part of the community, hearing about those aha moments, the times where the experiment does work, or for me, being a pathologist and being involved in patient care from the laboratory standpoint, making that diagnosis and then feeling when you go home that day, wow, I made a big difference in someone's life today. And now they're getting treatment that maybe they wouldn't have received. And from the science standpoint, looking under the microscope for the first time and seeing spirochetes squiggling around under the microscope on a dark field exam, those are things that I think are very inspiring. But even still, those don't happen every day. So the community is really important. Hearing what other people are doing and knowing that we're all working together to help patients, that's what inspires me.
I have really been inspired by our conversation here today. Dr. Stier, Dr. Pritt, all the best.
Thank you, Kathy. It's a pleasure.
Thank you.
Tomorrow's Cure is a co-production of Mayo Clinic and PRX. Our producers are Deborah Balthazar and David Newtown. The show's edited by Genevieve Sponsler. Our sound engineer is Tommy Bazarian. Our theme was composed and produced by Terrence Bernardo. Tony Carlson is our production manager, and our executive producer is Jocelyn Gonzalez. The Mayo Clinic production team includes Hui Hong Ang, Margaret Shepard, Samantha Clarkson, Kara Mangold, Felipe Sosa, Kim Ona, and Bryn Sankey. Special thanks to Preston Spire for audiovisual production support. Be sure to follow Tomorrow's Cure wherever you get your podcasts. I'm your host, Kathy Wurzer. Thank you so much for listening.